Welcome back to the latest episode of Taking Charge of My Cancer, episode 89. And I'm so happy to finally get to this podcast. One of my really favorite people out there that has been doing such a wonderful, wonderful work working on prospective surveillance breast cancer lymphedema program and really try to lead a team that is creating a lot of great new discovering in how to manage lymphedema and really kind of has been kicking out of our feet because a lot of things I learned I'm finding lately that is not how I learned it, that we should be doing this. I'm really excited about having with me Louise Kolmeyer. She is an associate professor um, and is the head department of health science and director of the Australian Lymphoedema Education, Research and Treatment Alert Program with the Faculty of Medicine, Health and Human Science at Macquarie University in Australia. Louise is a lymphedema therapist, occupational therapist, educator, and researcher with over 30 years of experience in both public and private setting, specializing in breast cancer rehabilitation and lymphedema management. She's involved in strategy managing and developing the education, research, and treatment arms of the innovative and international recognized Center of Excellence multidisciplinary program. Louise is a member of the Alert teaching faculty offering ALA accredited lymphedema training programs for health professionals. She develops and presents education workshops and advanced skill-based models on all aspects of assessing and management of lymphedema locally, nationally, and internationally. Her area of interest is on the prospective surveillance model of care and early detection and management of lymphedema and innovate advances in management. Louis' research interests as in achieving better outcomes and innovate early and advanced lymphedema management through conservative and surgical treatment. She's also interested in the assessment of management of head and neck lymphedema, surgical options, and the use of iodine green lymphography or ICG to personalize management. Louis' clinical interests and expertise are in developing and therapeutic relationships with individuals and personalized treatment programs that support the individual's needs and goals to achieve positive outcomes. And I can continue on and on. Louis, it's a pleasure to have you finally here with me today.
Thank you very much, Darlie. It's lovely to be talking to you today.
That's awesome. And thank you for doing this. I think it's 7 o'clock in the morning in Australia tomorrow. So thank you for doing that.
My pleasure. Great to be here.
Okay, great. So will you tell me about your role or mission, and were you always planning to do this?
Yeah, so thanks, Darlie. So as you introduced me, I'm an occupational therapist and lymphedema therapist, and I've been working in this area of lymphedema, lipedema, and chronic edema management for over 30 years. Just remember, I started when I was 5, just so you know.
Yes, important.
But for the last 12 years, I've had the pleasure of working within an academic institution at Macquarie University in Sydney, Australia, where we have developed a multidisciplinary translational clinical research and education program. And we have called it the Australian Lymphoedema Education, Research and Treatment Program, but that's a really long name. So we are known as the Alert Program. So you need to stay alert with Darlie and I over the next little while so that we can unpack some of the things that we're doing in our Alert Program. So at Alert, those 3 words in our name, education, research and treatment, are the 3 arms that our program works in. And very much the 3 arms of our program are very intertwined and interrelated, and one doesn't happen in isolation. So I can give you an example. We're in a multidisciplinary clinic where we have rehabilitation physicians, we have plastic surgeons, imaging specialists, lymphatic anatomy specialists, and lymphedema therapists, so who are allied health, physical therapists and occupational therapists working in our clinic. And we have patients come to our clinic from all over the country and New Zealand for our multidisciplinary assessment and management of lymphedema, lipedema, and all chronic edema. So they come to this very unique, specialized clinic that no other clinic is doing in our country here. Patients come into the clinic, they're first seen by our research team, and our researchers invite them to participate in our alert data bank, which is a data registry. So they're invited to participate in research, and we have over 95% of our patients consent to participating in our data bank, which shows just the importance of research for individuals living with these conditions, because they are so wanting help in this area and wanting us to find answers for them. So we take their objective measurements in the clinic, then they see a rehabilitation specialist, so get a full medical consultation, and then see our lymphedema therapist for the assessment and management of their condition. And depending on their condition, following their assessment, following their own personal goals of what's important for that individual, we can offer them specialist lymphedema surgical options, and we offer 3 surgical options: liposuction for advanced lymphedema, we offer lymphovenous anastomoses and lymph node transfer for early stage lymphedema. Or our other multidisciplinary clinic is our diagnostic clinic, which is where we use Indocyanine Green Lymphography, so ICG, to help map the lymphatics in real time so our patients can see what is happening to the lymphatics themselves. That's our clinical arm of the program. That then feeds into the research arm of our program, where that research data that we've collected helps us identify research questions that we want to answer. We analyze data according to the research questions that we ask, and that data is analysed, and then our publications take place. So we write in the medical literature to answer some of our research questions, which then is published in high impact journals, international journals. And then what we find is that research that's published then feeds into our education arm of our program. So we're an accredited lymphedema training program. We're accredited by the peak body in Australia and New Zealand called the Australian Lymphoedema Association, known as the ALA. And our course is accredited. And so health professionals who come and do training with us are getting the latest evidence-based practice from our own research and international research. And then they can go out and manage their own patients, feeling confident and competent that they've been given access to latest best treatment. And then in our own clinic, our own patients coming in for assessment and management are getting access to latest evidence-based management. So in a nutshell, we're very much translational. It's clinical research that we're doing, but then impacts real patients that are getting access to the latest evidence. And also health professionals are getting latest evidence to then impact and improve the lives of individuals across the country and the broader community.
And that has been amazing work. I was blown out the first time I hear you talking about, I want to say maybe 4 or 5 years ago on an NLN conference. I was like, oh my God, we gotta really start looking into how can we implement this. And as I mentioned before we start this podcast, I absolutely love Dr. Drew Singhal out of Beth Israel in Boston, who I have the pleasure to develop our lymph node transplant program here at UF in Gainesville a while back. I think he left maybe 5-6 years ago, and I know he has been in your side of the world and spend some time with the team over there learning more about the program for them to be able to implement it here in USA. And I know they're doing that already, which we are in the process of hopefully at one point be able to do that here as well at UF with the breast surgeon that I work with, Dr. Spiegel. So again, you're very inspirational, and I've been learning so much from you guys and really try to implement that. So I'm really want the audience out there that are physical therapists, PTA students, to really create that a different impact in these patients, right? So for years we learn all these things as a lymphedema certified, we learn all these paths and drain pads and all that we felt that we were really know what we were doing. And we find with the new research, maybe we were not on the right track. And even with me, I teach here at the PT program at UF, and I telling the students now, what I showed them last year, this is not what we're doing this time. Things needs to start changing for the good of the patients. And so has been amazing. So I cannot wait to implement here for what you guys have there. So really exciting to hear that. What good resources will you advise patients to look into to educate themselves?
So I think education is one of the key things that we need to do as health professionals. Education goes across the whole aspect of assessment, diagnosis, and management. And we found during COVID times that even though we might not be able to physically put our hands on a patient during that time, education and self-management through education was vital. So I really believe that as individual health professionals, we need to develop a partnership with our patients. And I say that always from the beginning when I'm meeting a new patient, and I still do maintain a clinical load myself, even though I'm in an academic role, to keep me real and to keep me grounded so that when I'm doing my research or when I'm doing my teaching, I know what real patients are going through at the moment. I try to understand them. And my real area of passion is in breast cancer. And so when I meet someone, I start that education. I call it a drip filtering of education that I don't think as health professionals we can do a tick box. We've done a 1 hour education session and say, yep, I've educated them. They know everything I need to know. I really believe that people are going to pick up little parts of education along the way. Mm-hmm. And so like that drip filter coffee machine, we need to give little bits of education so that the patient can understand it. And I don't even like saying the patient. It's a person here. Remember, it's person-centered care. So that individual is in front of me and they've got a whole lot going on in their life. They may have just been diagnosed with cancer. They may have just been diagnosed with lymphedema and can often feel really, really overwhelmed. And so I need to develop a therapeutic relationship with them so that then I can start imparting small amounts of education along the way. At Alert, we're a Learn Centre of Excellence, so the Lymphatic Education and Research Network based in the US. We're very proud and feel very privileged to be a Learn Centre of Excellence. And I would often refer patients to the Learn hub of resources and education. It's an excellent resource. It's internationally targeted, and I would certainly refer my patients there. We also have some local educational resources. So we have the Australian Lymphoedema Association has an education part for both health professionals and consumers to go to. And we also have our own Cancer Council organisation. So we have the Cancer Council. They have a great lymphedema education handout that you can access online. And we also have the Breast Cancer Network Australia, which also has a really good education guideline on managing lymphedema. So they're probably the three education sort of resources I would go to: Learn, the ALA, and then the cancer organisations, Cancer Council Australia, and also Breast Cancer Network Australia. But I know there's a number of educational and advocacy organisations in the US, probably the National Lymphoedema Network, NLN, is a great resource as well. These days we are filled with, fantastic resources online. I think the key with education, though, is that we need to be aware of where that source is coming from and hopefully that it's updated with latest evidence. Because I know in my career, I'm now educating patients in often the opposite education message to what I was doing 30 years ago.
Yep.
And sometimes there's myths out there that haven't been proved by research that are really still out there on the net that we need to perhaps challenge ourselves in communicating and educating our patients.
That's true. And then, as you know, many of us who are, we call it veteran therapists, but I call it seasoned therapists, right? That we've been doing this for a long time. sometimes I feel like even though it's hard to sometimes do research, just because you have to have all the right tools and the right support and the time to be able to do it. But we know anecdotally, we see a lot of things in clinic that we know works. And sometimes, you may just have to just, trust on that and see like, okay, I always been known that we should be having a drain pad to the axilla. Even if I was told on my training not to do that, but I kind of listened to my gut feeling that this is what I get in the best response from my patients, and I'm gonna continue doing it, even though I was taught not to. And look, all the evidence that now you are having to show that's actually the pattern that most of the lymphatic fluid goes to on the arm. So again,
And I
sometimes.
think also, Julie, that as a lymphedema therapist, we have a toolbox of various treatment strategies. And I think that's why I'm passionate and love working in this area, that I'm not implementing the same strategies for every single person. I have the overarching complex lymphedema therapy, or CDT that you call it in the US, and I understand how to manage patients with that treatment. But until I've got that individual person in front of me and I understand about their life and how this condition is impacting their life and what are their goals of therapy, I can often have patients come into me and they will say, there's no way am I wearing one of those compression garments. And I know that they may have been doing therapy shopping, going around to different lymphedema therapists, and they've been given compression garments because that might be, in theory, the best way to manage their condition. But unless you get them on board and understand their motivation for treatment, their time commitment, what's going on in their life, we need to work with them, educate with them, and often they will come around to wearing a compression garment in their own time, but it may be after that they've tried other techniques in their toolbox of self-management in order to get to where the outcome they're wanting. And I think that's the exciting part of working in this area.
Yeah, yeah, you're absolutely right. It is so important because, again, as you have been managed this, not just breast-related lymphedema, but as well just general lymphedema, right? It's so hard when you have these chronic patients, over and over, and the compliance on it. So I think that that's the key. The key is like try to educate them and make them understand that this is not just one problem, right? It's not the lymphatics problem, it's a whole system problem that we got to start to really look from what's causing all this. It's not just the damage to your lymphatic system, but how can we open all these neuromuscular system, muscular skeletal system, nerve systems to try to really get all the lymphatic system working in the right direction. So I think it's really important. Um, can you give us 3 valuable tips for patients who has been diagnosed with cancer? In this case, maybe head and neck, and then or breast.
Yeah, I think for all individuals who are diagnosed with cancer, and are at risk of lymphedema, no matter what the cancer is, if they're at risk of lymphedema, they need to have access to a prospective surveillance and early intervention model of care, which includes education, which includes partnering with a lymphedema practitioner, and then developing their goals to either prevent lymphedema, manage lymphedema, detect it early, and then be offered best practice. So I think it's really important that we want to get access to these patients really early. I sometimes have patients who say they feel really ripped off or unhappy when they weren't offered a prospective surveillance and early intervention model of care, when the research is out there to say that prospective surveillance and early intervention really does benefit and reduce the incidence of chronic long-term lymphedema. So I would really encourage anyone who's at risk of lymphedema to be linked in to a clinical team that can offer screening or monitoring and education. I think exercise is really important. Exercise is important from a whole range of aspects, but the research is very strong in showing after cancer treatment, exercise is important at reducing the risk of or development of lymphedema, Plus also it helps psychologically and physically someone to recover from the breast cancer. So these days we do a lot of intensive treatment for breast cancer or other cancers, which is great. We've got great medical, surgical treatment, but often individuals finish their treatment and they're impacted not only physically, but functionally and psychologically. So we need to partner with them, and exercise and listening to what the needs are of the patient is really important.
That's very well said. Um, Tell us a little bit about your ICG and MLD. So, how is that? Like that totally, when I saw you guys researching regarding really what is the path that you have seen happening with our lymphatics, mainly we're looking into upper extremity, right, for breast-related lymphedema. So how do you like how that has been impact you on the change and how you and I learned these years ago, and really how like in my mind sometimes I'm like, okay, this is not how it works. We don't have this anastomosis, so we're taking that out our education and we need to start to implement the new things. So just tell us a little bit about that.
So the background to this was we have Professor Swami, who came from the MD Anderson Cancer Centre in the States and came to start working in our alert program. And he brought the ICG imaging technique to our team, initially in a surgical setting. So we were using the ICG to help us in guiding where we do lymph node and anastomoses and help in our lymph node transfer surgery, so in our microsurgeries. And we were doing our surgeries using ICG for a period of time. We then trained Hiro to become a lymphedema therapist. He's a medical doctor, he's a plastic surgeon background, but he participated in our lymphedema training. And when we started looking at what they were doing in the surgical setting and how they were able to see what was happening in this superficial lymphatic system using ICG, our therapists and I thought maybe we can use this in a conservative setting. And that was really the beginning of the work that we've been doing since 2017 here in Alert. So we've now got this multidisciplinary ICG clinic where we've trained some of our lymphedema therapists to be ICG technicians along with Hiro, so that we can actually have this clinic where we have 2 rooms operating on a daily basis, where we have patients coming in, and they come in for about 3 to 4 hours when they come into our clinic to have this imaging technique. What the imaging does is the injection, which has all been published, so I'm happy to share our published data with people. We inject into the superficial lymphatic vessel. Usually we start in the base of the fingers in the hand. And then in real time, we monitor with an infrared camera in a dark room what we're seeing under the skin. And this has been mind-blowing. For me, as a lymphedema therapist who's been practicing for 30 years, this is the first time that I've been able to see what's happening under the skin and what is the effect of our MLD technique. So how I describe to patients is I used to be doing MLD, but I was doing it with a blindfold on. I didn't know what was happening underneath the skin when I was doing it. And it's really interesting because when I do the MLD technique that I was taught to do a long time ago, I would say, we don't see anything move underneath the skin through the camera. Okay, so on the screen, I do the light effleurage MLD technique that I was taught, and we don't see anything move in a congested area. What we do see is when we have congestion, and we call it dermal backflow, if we do a firm, slow MLD technique that we train therapists and health professionals in, we now can see the lymph fluid moving under the camera. So we see it, the patient sees it. So the patient might have been doing their own MLD for a period of time and thinking, is this really worth me doing? And now with the revised altered technique and pressures and speed of the MLD, we see the lymph fluid moving. We know that lymph fluid will only go where it wants to go. So lymph fluid does not move where I might want to take it. It will only move where it wants to go. And what we've found with our research is that where I was taught to do my MLD, so I was taught to take the fluid across to the contralateral axilla, I was taught to take the fluid down to the ipsilateral inguinal nodes, and also take it across the back of the individual, because on the side of where they'd had their lymph node dissection, the lymph nodes were gone, so there's no use draining to that area. That's how I was taught, and that's how in Australia lymphedema therapists have been practicing for a long time.
Yeah, same here.
What we've shown from our ICG research, and in just the upper limb alone, in over 500 patients, we've actually seen zero, I repeat, zero cases draining down to the ipsilateral inguinal region. So that means we actually don't teach our therapists or teach our patients to drain to the ipsilateral inguinal, because we're crossing a watershed and we have not seen that happen in our research, which again we've published. In regard to the ipsilateral and contralateral axilla, we have seen that overall, across all stages of lymphedema, that almost 80% of individuals with upper limb lymphedema secondary to cancer, they are draining to the ipsilateral axilla region. So where they've had the lymph nodes removed or radiation treatment, they are draining into the deep lymphatic system on that side. That is a light bulb moment for us, which we previously weren't draining to.
Yep.
What we find also is those with early stage lymphedema, it's over 90% of those patients are only draining to the ipsilateral inguinal and sometimes the supraclavicular drainage region. And those patients with early stage lymphedema, we don't even have to go across to the contralateral side. And what our research is showing, and this is where we say it's translational research, that we've analysed these results now 3 times as our sample size has increased. We're getting the same result, which means that we can then be more targeted in our MLD technique and in our education to our patients. We're not advocating that every patient needs to come and have an ICG, because we're able to translate the results into our education and out into podcasts like this, so that patients can start implementing best practice in their own self-management. So the key message from our upper limb ICG results is, if in doubt, drain to the ipsilateral axilla and supraclavicular region. If it's really stubborn and severe lymphedema, maybe you might want to go to the contralateral, but that's in far fewer cases. Start with the ipsilateral axilla first, and no need to do any MLD drainage down to the ipsilateral inguinal node.
Got you. So as I mentioned, Louise, before we start the podcast, because we don't have the technology or the staff yet to be able to do that yet, that's what I would love for us to move to. But what we've been doing with my dear surgeon, Dr. Lisa Spiegel, is she start mapping. She used the ICG for the lympha, which is the venous LV bypass anastomosis at the time of the mastectomy or a lympha procedure. She has been mapping it for us and put it on the media tab so I can see it. So when the patient come to us, we can see where is this happening. And when we have seen it, she really started doing that more in the last, want to say 6 months, that she actually started put it, like be really like mapping it and put it on the media tab for us to see. We have seen 0 patients with any drain on the lateral part of the arm. None of them. Every one of them has been like a medial axillar like pattern, like ipsilateral, and just kind of really medially. Like none of them has that much anything lateral or even posterior. So it has been like every one of those has been like that. Have you noticed that pattern as well?
Yeah, so we're Drew Singer, as you mentioned him, in the Boston Lymphatic Centre, and they're what we call a sister program of us. They're also a Learn Centre of Excellence. They're doing a lot of research in the anatomy area and looking at those pathways. Our own Hiro Swami has done cadaver research looking at the normal anatomical pathways. And I think in our research, being the sort of translational research, we are finding various pathways, but they're ultimately going to that ipsilateral axilla drainage region.
Okay, great. Um, how I think we already talked about how this new research had impacted treatment for lymphedema. I think we pretty much cover all that. I
Yeah, the
like.
only thing I would say though, Durley, is that this ICG research has also impacted our other self-management, conservative management. So it's really impacted the way we measure and prescribe compression garments, because based on the ICG results can help us in guiding the type, the style, the fabric, and the class of compression that we might recommend for someone, particularly in the lower limb cancer patients, because we find that about 25% of our patients with lower limb lymphedema after a cancer diagnosis actually drain to the contralateral inguinal nodes. And what we find is that if those individuals have been prescribed with lower limb thigh-high garments and only thigh-high garments, they often present with what we call in Australia sort of a muffin top at the top of the thigh-high garment, and they might have gluteal congestion and perhaps some abdominal edema. And so for those oncology, cancer-related lymphedema of the lower limb, we would prescribe a garment that has got compression along the abdomen area. So we might put them into bike shorts or a one-legged panty garment to be able to add compression to that area to try to avoid the muffin top and help give the adequate compression. So compression therapy. Also, we're using a lot more of pneumatic intermittent compression pumps to help guide based on our ICG findings. And that also means that the speed that we might set the pump or the pressure that we might set the pump has also been altered based on our ICG findings. And then, of course, we encourage the exercise and the good skincare along with our education.
That's so great to know. Have you noticed any changes on the garments for upper extremity based on that?
Sometimes, yes. So sometimes if someone doesn't have any dermal backflow in the hand, perhaps sometimes we may be able to get away without doing a full finger hand glove. Sometimes if someone's got normal drainage in the upper limb, maybe they can go with a long glove rather than a full arm sleeve. So yes, the combination of compression for the upper limb does vary according to our assessment, whether they've got dermal backflow, whether they've got deep pitting edema, which means a sign of dermal backflow in the limb. That will all put the pieces in our puzzle together in prescribing, and what we say is personalized management for the individual based on their assessment findings.
Oh my God, that's new to me. See, I'm already learning something new. That's amazing. We need to start to kind of like work on that with our patients because we just on the process of the MLD, but we haven't been doing anything with the garment. So that's such a great information.
Yeah,
Uh,
and we're now looking at some outcome data. So when patients have the ICG in our clinic, we give them a report, a 10-page report of the outcomes, giving them the results of the ICG and a self-management recommendation. And now what we're doing is when our patients come back for follow-up by our team, we're looking at have they carried out the recommendations and have there been objective changes to their lymphedema.
wow, that's amazing. What is a common question, sorry, that you find uh, oncology or cancer patients have for you, and will you share some of that information today?
I guess the common questions people have is, am I going to get lymphedema? what is my risk for developing lymphedema? How can I be monitored and picked up early so that I can prevent getting long-term lymphedema? And so I am a really big advocate for the prospective surveillance and early intervention model of care. I think it doesn't necessarily matter how someone is screened or monitored, but to be linked into a medical or therapy team that takes some objective measurements and a comprehensive assessment so that we can pick up the earliest signs of subclinical lymphedema, intervene early with compression therapy, with exercise, so that we can prevent the longer term effects of living with chronic lymphedema.
That's great. How can people find you? And I'll put the specific information on the show notes so they can click into that, but what will be a good place to find you?
Sure. So we have resources on our website. So our website is mqhealth.org.au/alert. mqhealth.org.au/alert.
Excellent. So what will be one question you wish I will have asked you and you have answers to wrap up?
I think just that we are a centre that we want to work with our partners and friends in the US. I think we're not very far away and technology has helped us. So just to continue the conversation, I guess, moving forward so that we can share our education. Probably I would also just put in a plug for our contemporary evidence in lymphedema management course. So as an education provider, we have this contemporary evidence online education module. It's a unit of study that we would be really pleased that health professionals in the United States could access and can learn further about prospective surveillance and early intervention. And importantly, the majority of that unit of study is on our ICG research and practical implications for management moving forward.
That's amazing. Oh my God, Louise, I can pick your brain for another hour, but I know you have to go. A really quick thing. Tell me about your head and neck experience. It has been any research, like really quick, because I know you have to go.
Yeah, so with our head and neck, that's an area that we've done some pilot studies where we're using the ICG imaging again. So we've developed and publishing a protocol on using ICG in head and neck cancers. We're just about to publish our early results where we're showing the drainage regions and recommendations for self-management. We do have an online course on managing head and neck based on these results that we're about to publish. So stay tuned. Those results are currently being prepared for publication.
Awesome. I would love to know as soon as possible. I'm super interested, and since this is another really big thing we do here, so that would be really great to see that. So I'm tuned to look forward for that.
Okay, great.
Thank you, Louise. I really appreciate your time and 7 o'clock in the morning podcast in Australia time. I really enjoy it, and I'm hoping to see you hopefully the next time you're coming to the States to present.
Great. Thanks very much, Dolly.
You have a great rest of the day over there.
Thank you. You have a good evening.
You too. Bye.
Bye-bye.